condyle generally, and extension of the wrist and extension of the digits. Okay, so it's just an opposite kind of story. So 11 total muscles in the forearm, here the posterior forearm. They're laid out pretty, they group nicely, I guess you could say. All of these muscles are innervated by the radial nerve. So we generally associated the anterior forearm with the median nerve. There's a little bit of ulnar nerve in there. Side here, it's all radial, buddy. It's all radial and some of the derivatives of the radial nerve. So deep branches. We'll talk about the details. And again, associated with lateral epicondyle. So medial epicondyle, you're thinking flexors anterior. Lateral epicondyle, you're generally thinking extensors posterior. So we can see our person here in pronation. So they're pronated over, so their palms facing down. So this mass of muscle here you would feel on the back side. This would be on the lateral side of the cubital fossa. All this is this extensor mass here. All right, so we have two different distinct layers, so a superficial layer and a deep layer. And we'll go through each of these little layers and talk it through. Okay. So starting with superficial compartment, the first one that we'll see, remember this is the lateral border. The lateral border of the cubital fossa, brachioradialis. The brachioradialis muscle, even though the posterior compartments, which is we associate generally with the extension of the wrist and digits, is kind of an outlier in that its action is a little bit interesting. So the brachioradialis muscle actually comes from way up high. It's actually not even coming from the lateral epicondyle. It's so high it's coming from that lateral supracondylar ridge. It'll go down, down, down like this and attach onto the styloid process of the radius. So the brachioradialis is actually a flexor. It's a flexor of the elbow, but only after getting your hand into a certain position that it wants it in. So if you're in supination like this, and you fire your brachioradialis muscle, the first thing it would do is pull your hand into this position. It's like a mid-supination, mid-pronation position, and then it would flex your elbow. Just the opposite. If you started from a pronation position and you fire the brachioradialis muscle, you're like, okay, brachioradialis, go. It would just pull your hand into this position, this kind of mid-supinated, mid-pronated position, and then it would flex your elbow. So it's lovingly known as the beer drinking muscle, because we all drink beer from this mid-pronated, well, I do anyway. Maybe you drink it upside down from a keg or something, I don't know. But you're in this position generally, right? You're in this mid-pronated, mid-supinated position, and then flex the elbow. So brachioradialis is a good way to remember. Remember, very importantly, a very important anatomical relationship, brachioradialis, with the, as being the lateral border of the cubital fossa. And of course, radial nerve. Radial nerve. Moving our way down here, still in the superficial compartment, we'll see two wrist extensors. This is nice. If we just notice these names, we'll see a long one and a short one. Longus and brevis being short. See an extensor, so we know we're on the back side. We know it's not going to go to a digit. It's just going to cross the wrist, so it's a carpi. And it's on the radial side, not the ulnar side. So extensor carpi radialis longus, and ECRB, extensor carpi radialis brevis. They'll track down together and attach onto the base of the second metacarpal and the base of the third metacarpal, respectively. All right, so you could guess then, if you're using extensor carpi radialis longus and brevis, this is going to help you with wrist extension. These are innervated by radial nerve and radial nerve derivatives. Okay, so radial nerve for ECRL, and the deep branch of the radial nerve for ECRB, extensor carpi. And that's it. That's the superficial layer. We call these the radialis group of the superficial layers. We have brachioradialis, extensor carpi radialis longus, and brevis, and that's got us covered. Not too bad. All right, so moving in more. So we're moving medially now, technically. So we've been on the lateral side, moving medially now. We see one with a very tight relationship with the lateral epicondyle, so posterior view of the forearm and elbow. We see a large muscle mass. So back in the day, they called this extensor digitorum communis. It's been just kind of shortened to extensor digitorum now. You can probably guess the function of this one. So extensor digitorum is going to extend the digits. So it's on the back side. So if we're doing some kind of extension, we're thinking backside stuff. And luckily, with extensor digitorum, you don't really have a superficialis in like we saw in the anterior forearm. You just got one. So extensor digitorum. And it actually travel all the way out. You can see it travels across the wrist. So since the tendons cross the wrist, they can't help but act on the wrist a little bit, so they would technically help extend the wrist. And they would go all the way out to the phalanges. And the way they would attach actually is via this complicated little, what they call the extensor expansion, or the extensor hood. This is a very complicated sort of pattern of these tendons coming in to go into the posterior aspect of the fingers. You have these little collateral slips, you have a central band. All of these working together as an extensor expansion to just extend the finger out, that's it. These are actually pretty important clinically, and we'll talk about more of that next block or next semester. All right, not so bad, so extensor digitorum. There's a little tiny guy off the side of extensor digitorum. Its muscle mass is not independent from extensor digitorum. So if you're in the dissection lab and you find this little dedicated tendon for the little digit, its muscle mass is really extensor digitorum. So it's now to the little digit. So the extensor these are derivatives of the radial nerve. Okay, so radial nerve derivative. All right. Now we're going all the way across to the medial side of the forearm now. So we're back on the ulnar side of the forearm. We have flexor carpi ulnaris, and now we see its partner on the other side, the extensor carpi ulnaris. So extensor carpi ulnaris labeled there. So you expect this one to cross the wrist, not going all the way out to the phalanges. And it's going to help with wrist extension. Also innervated by radial nerve derivative, posterior interosseous nerve. We'll take a minute just to talk through these actions that we mentioned. So we talked about the flexors at the wrist. We talked about the extensors at the wrist now. This is the end of the radius. So here's the radius. You see the little articular surfaces for the scaphoid and the lunate here. This is the head of the ulna, and there's a process. So all the muscles we mentioned last time, they're helping with flexion of the wrist. Now we're talking about the ones that extend the wrist. If you think about how we get into ulnar and radial deviation, we have to be kind of thoughtful about how we achieve these positions. Because if you think about flexion and you think about extension, ulnar deviation or radial deviation is not really a flexion or an extension. It's kind of a sideways thing, right? So in order to get our hand going out sideways like this and rocking back and forth on the radius like that, we use a flexor and an extensor at the same time. So their flexion and extension abilities will cancel. So the only vector that's left is going to be pulling it straight out. This MCAT physics vectors. I don't know. So if you fire your flexor carpi ulnaris at the same time that you fire your extensor carpi ulnaris, then the extension capability of the extensor is canceled by the flexor capability of the flexor, and you just go straight out. So that's how you ulnar deviate. So flexor carpi ulnaris plus extensor carpi ulnaris will help you ulnar deviate. And the same exact story for radial deviation. You have flexor carpi radialis on the front, and you have the two extensor carpi radialis muscles on the back. Okay, does that make sense? Ulnar radial deviation. All right. So it's wrapping up the rest of the superficial layer. So we're done we're going to some of these digits out here after the non-radialis group, if you will. All right, so now we get into deep compartment. So the first thing, let's talk about these two first. We talked about the supinator last time. So the supinator muscle is going to be the antagonist muscle to our pronators. So we would see it coming off a little bit of the lateral, a little bit of the ulna here as well, the olecranon. It would wrap around, attaching onto the radius. So if you're in a pronated position like this, you'd be stretching your supinator because the radius would be coming across. You'd be stretching the supinator tendon. So whenever you fire the supinator, it's going to pull it back into this supinated position. Another one that you'll see down here in this deep compartment, among others that we'll discuss here, is the extensor indicis. So the index finger here is your second digit. Remember, thumb is number 1, index number 2, pinky number 5. The extensor indicis is actually a tiny little muscle. It's deep. It would be underneath the muscles that we discussed in the last slide. And it is a dedicated little tendon that goes all the way out to the distal phalanx. extensor expansion. So a lot of times you can see if your hand's wired up just right. We don't keep very much subcutaneous tissue on the dorsum of the hand. The dorsum of our hand is pretty lean, is how I would say it. So if you look at the back of your hand like this, and you're in a fist, and you extend your little or your index finger, you might see one tendon roll over the other. You see that? Just me. You see it? So that's the indicis tendon rolling over the extensor digitorum tendon. So we have a dedicated tendon for that, which is kind of neat. So thinking about the radial nerve, so I've talked about that a little bit. The radial nerve is wrapping around, so remember it's around the mid-shaft of the humerus in the triangle interval. The radial nerve has a couple of branches that are important to know. It will wrap around and split into the superficial and the deep branches. When we're talking about muscles in the posterior forearm, some of them get direct radial innervation, and some of them get deep branch of the radial nerve innervation. Okay, ECRB and supinator. They get deep radial innervation. The deep branch of the radial nerve will either penetrate the supinator, as you see here, or maybe it goes under the supinator, what we call the arcata fruge. You can have what's called supinator syndrome here. If you're a person that supinates a lot as part of your job or something like this, maybe work with your hands, and you get a hypertrophied supinator and you hypertrophy the fruge right there, it can pinch down the deep branch of the radial nerve and give you issues. There's supinator syndrome. But long story short, the deep branch of the radial nerve, after innervating those two muscles, will pop out. Okay, it pops out from underneath the supinator, and when it pops out, it's the same nerve, it just changes names to the posterior interosseous nerve. So we have the anterior interosseous nerve, that thread-thin nerve that's in the anterior forearm, and now we have a posterior interosseous nerve, which is the terminus of the deep branch of the radial on the posterior side. So when you're studying the extensor compartment of the forearm here, you'll see some muscles get pure radial nerve innervation, some get deep branch of the radial nerve innervation, and most of them will get posterior interosseous nerve. Okay, all derived from radial. So if you, for example, if you had a radial nerve lesion like way upstream, if you had a radial nerve lesion like right here, it's everything downstream that's cooked, right? It's all done. So it doesn't matter who gets what at that point. All right, so these are fun. I like these. So also in the deep compartment, we have what's called the outcroppers. So the outcropping muscles are sort of veering off, and they're going to be dedicated to our thumb. Okay, so our thumb is, like I said, super important. It's what makes us super capable out there. We have a very unique thumb, and we'll talk about the thumb some in the wrist and hand lecture. So under these outcropping, under the last group that we discussed, under this group, so if you're doing a dissection and you go underneath the extensor digitorum muscle like this, seeing these outcropping muscles. So we mentioned the extensor indicis in the last slide. Now we see a bunch that trail off going toward the thumb. Okay, so I see right in a row here. Here's abductor, abductor, pollicis longus. I see a thumb extensor, extensor pollicis brevis. And then I see the one we mentioned earlier. This is EPL, extensor pollicis longus. So abduction, extension brevis, extension longus. You'll see each one of these going to the three bones in your thumb. So abductor pollicis longus will go to the base of the first metacarpal. Extensor pollicis brevis is, the artist is really overshot. It's usually a very thin tendon, but it would go to the proximal phalanx, and then the EP pollicis longus will go all the way to the distal phalanx. So you can kind of feel that. So we saw if you go into a hitchhiking, this thumbs up kind of position, you can see and normally feel your extensor pollicis longus. You might also notice a little wad of tendon that is lateral to that. Okay, so you see EPL, and there's a kind of a thicker tendon that's lateral to that. That little tendon that you feel is actually a combo of abductor pollicis longus and extensor brevis. You can see how close they run together here. All right, so outcroppers. Remember, you see pollicis, you're thinking about the thumb. That's some sort of thumb giveaway. So with that said, let's talk about the actions of the thumb. So the thumb is a bit enigmatic when it comes to its movements. Definitely different than the fingers. So I'll do it together now because it's fun. So if you flex your fingers, your nails go down. If you extend your fingers, nails come back. Now I'm sure you've done this before, trying to focus on studying genetics or whatever it may be. Have you ever had a good look at your thumb? Have you ever, I mean, have you ever really looked at it? If you do, if you look at your thumb, you know, for longer than 30 seconds, I guess, you may start noticing that the plane of your thumbnail, if it's just held in a natural position, the plane of your thumbnail is sort of 90 degrees to the plane of your fingernails. You see that? Natural position. Your thumb is not rolled out like a finger like this. It's hanging off the side. Yeah. All right, so if you flex your thumb, nails go down. That's flexion of the thumb. If you extend your thumb, nail comes back. So this is extension. This is thumbs up is extension of the thumb. And you might say, okay, I believe you. That gets complicated though when you talk about abduction of the thumb, which is moving the thumb away from the hand's midline. The midline of the hand is considered your middle finger. So when you abduct your fingers, they spread apart away from the middle finger. And when you adduct your fingers, you add them back together to the middle finger. But your thumb, you don't really do that like that. The way you abduct your thumb is you move it away from its natural plane. So abduction, abduction of the thumb is like making a C. So if I said make a letter C with your hand, you would kind of come out. So this is abduction of the thumb. Extension is thumbs up. Does that make sense? All right, so we have these movements. Adduction would be adding it back. Extension is thumbs up, flexion not too bad. We're also able to do this really cool combo movement of the thumb called opposition. So opposition is a combination movement where we use some opposition muscles to swivel our metacarpal around such that we kind of abduct and flex at the same time, such that the pad of our thumb is facing our palm. This is opposition. So it's like a combo movement. All right, very important, very important. We'll talk about thumb nerves in the next meeting, and I mean, out of control. I mean, the surgeons are worried to death about this. These people have thumb nerve posters up in their offices. It's crazy. All right, so we did the deep layer. We're good with deep layer. We know they're part of, we got some outcroppers. We talked about extensor indicis in there as well. And we talked about supinator. Remember radial nerve and its derivatives up here. When you think posterior arm and forearm, you should be thinking radial nerve. All right, just some other randoms in here. Remember the blood supply for the forearm is actually not too bad. You just have the one artery. You have the brachial artery, and we know there's a little interesting anastomosis around the elbow with these little tubes here. The brachial artery bifurcates into a radial artery laterally and an ulnar artery medially. And you'll see coming off the ulnar artery, we'll call it common interosseous artery. I mentioned it last time. If you see the name common, like baked into an anatomy term, it's usually either having received two or about to split into two. It's common to two things. So the common interosseous artery would bifurcate into that anterior interosseous, which we saw pass on the anterior surface of the interosseous membrane, and the posterior interosseous. So you can see Netter's drawn this in. You can see this guy is kind of ghosted in behind. You see that red artery? So it's on the posterior side of the interosseous membrane. So it may be close, but anatomically that's worlds away. Okay, so it's going to pop out and run into the posterior forearm. So it's an important blood supply. I mean, your whole posterior forearm is, and most of its muscles are relying on this posterior interosseous artery. And we mentioned the posterior interosseous nerve. Right? The posterior interosseous nerve is a derivative of, it's a continuation of the deep branch of the radial. It just changes names when it pops out from underneath the supinator. All right, let's test your anatomical acumen here. If I put a tag here and said ID the nerve, what do you think about this nerve? I have a couple of bony clues here, right here and right there. What do you call that nerve? Think about medial lateral. You're pretty close, yeah? So we're in the posterior arm, so the median nerve would be in the cubital fossa on the anterior side. What is it? The ulnar nerve. The ulnar nerve. So this is the ulnar nerve running in the cubital tunnel. So that's the cubital tunnel. There's the medial epicondyle, and there's the olecranon process. So That's right where that cubital tunnel would be. Median nerve, second best guess probably. So the median nerve will be on the anterior side, passing through the cubital fossa. Through the cubital fossa.
And that's that medial tunnel.
Say again.
And that's that medial tunnel that we see.
This right here?
Yeah.
Yeah, this is the cubital tunnel. Yeah, the cubital tunnel right there. All right, have to talk about these. It's against the law to give forum lectures and not talk about these very, very just common clinical correlations. So the medial and lateral epicondylitis. So whenever you're dissecting these muscles in real life, the students, you find the muscles, you can find their tendons downstream. They're pretty fat, easy to find. But when you follow, for example, the flexor mass, all of these muscles, pronator teres, flexor carpi radialis, palmaris longus on the front side of the forearm, if you follow them actually back to where they originate on the medial epicondyle, or you follow the extensors, all these extensor digits, if you follow them back to where most of them come from the lateral epicondyle, it's almost like they form one giant muscle mass. Okay, it's just like one giant blended muscle origin from these epicondyles. So since they have like a large shared origin like this, they tend to have a giant shared problem. So if you're overusing the flexor compartment, you can get medial epicondylitis. So the muscles around here can just become irritated. You can have some degree of tendinopathy in there. Maybe you're starting to make micro tears or something, and you have pain. This is classically known as golfer's elbow, which kind of makes sense. If you think about swinging like this, you're putting this sort of pressure under your elbow here on the medial elbow like this, and you're putting that strain on the medial common flexor origin. And then, like if you're doing a lot of backhands and tennis, tennis player, everyone's familiar with backhand like this. So if you're doing like this, then you're kind of doing the opposite sort of strain on the lateral epicondyles, common extensor origin. Okay, so the history could be relevant. They come in, they play a lot of tennis, they do a lot of golfing, localized pain and tenderness. If it's medial epicondylitis, it could be reproduced by wrist flexion, digital flexion. If it's lateral epicondylitis, it could be reproduced by wrist extension, digital extension. All right. Not so bad. So let's talk about the dorsum of the hand. So the back of the hand. And you might be looking at the schedule and say, hey, you've got a whole lecture for hand. I thought you were talking about it next time. So the palmar surface of the hand is just white hot fury. It is 50 minutes is a lot. The dorsum of the hand is not so bad. And since so many of the extensor muscles are kind of crawling across the dorsum of the hand to get out to their skeletal targets and or wherever they may be going, it kind of makes sense to go ahead and talk about that now. So the dorsum of the hand. So if you take the skin off of the dorsum of the hand, there is very, 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 very little superficial fascia. So there's basically no fat at all on the back of your hand. There's very, very little. Some things that you might see back there, you might see that dorsal venous arch. I mentioned it before. There's no picture of it here, but remember the cephalic and basidic vein would start there. That's why you can look at the back of your hand and see a bunch of veins. You'll see some tendons back there. So famously the tendons of extensor digitorum. You might see the tendon of extensor indicis in there as well if you're extending your finger, kind of back and forth like that. You'll have an important muscle, kind of a wad of muscle here between your thumb and your index finger, between the first and second ray is what you'd say. This little wad of muscle is the first dorsal interosseous muscle. And then we saw the EPL, so there's extensor pollicis longus. And remember I said that you can, if you feel where your extensor pollicis longus is, or if you extend your thumb like this and you're able to get it to pop up, if you feel lateral to that, you'll actually see a combination of two tendons, the abductor pollicis, extensor pollicis brevis. They're kind of packed together. So everyone, if you were to extend your thumb like this, you might notice like a natural little pocket right there between these two tendons. Does everyone see that? Okay, high yield pocket. We like this a lot. Everyone, this is the anatomical snuff box. This is important for so many reasons. So many reasons. So just a little history on the origin story of snuff box. Does anyone know what snuff is? Do you really? Tell a class. Go ahead.
Well, I learned this from my other anatomy class that, back in the olden days when surgeons and doctors would do crazy long hours and stuff like that, it was called the snuff box because they would literally do speed, blow, whatever, and then go into surgery.
That's right. That's right. That's right. So hopefully you're taking notes. So that's the history on the anatomical snuff box. So yeah, they would put snuff in there. This is before vapes, right? So you're gonna get her fixed a little pocket. So they would put snuff in there, and they just snort it. So it's like a little pocket. It's important clinically for lots of reasons. So I'll talk about it some now. And in the spring, when we talk about the wrist and hand and radiology, I mean, this is out of control, man. These people just love the snuff box. The scaphoid fractures, my goodness, is out of control. Very common bony fractures that you'll see in the wrist. Usually tenderness, snuff box tenderness is a term they'll use a lot. That you would encounter at all levels, man. Primary care all the way through neuro-orthopedic space surgery. Everyone's heard of this. All right, that's great. So let's talk about how these sheaths, so remember in the last lecture I talked about the carpal tunnel, and a lot of the tendons that are going to flex your digits up here are passing through this tunnel, bound by kind of a broad connective tissue sheath called the flexor retinaculum. That would be like the roof over the carpal tunnel. That's the one they cut if they do a carpal tunnel release. You have similar to that a retinaculum on the posterior aspect of your wrist. And these retinacula, honestly, they're actually just kind of thickenings of the antebrachial fascia. So when you cut if you're doing a dissection and you cut through the skin, the muscles just don't start popping out. Remember, you see this in images like this, but remember, it's all packed into a fascia. You have to dissect through the fascia to see the muscles. Yep.
Is this where ganglion cysts?
Yes. I have it on the slide, I think. But so ganglion cysts will pop up back here. Yes. And they're usually related to the synovial sheaths that we talked about in the last one. So yes, you predict in the future. Excellent. So the would just connect here. So to get a nice extensor retinaculum, we would just say to students, like, okay, just decide where you want the extensor retinaculum to be. Cut the antebrachial fascia off, revealing the extensor muscles, and leaving the retinaculum on. The retinaculum is, you can see, so it's going to come into contact, sort of creating these little channels or these little tunnels here for these tendons to pass through. And the tendons, just like in the flexor compartment, they have these synovial linings. So you see these little blue linings. These are just synovial linings that facilitate movement, so you're not building up friction and everything's moving smoothly in there. And there are 6 different channels or tubes, compartments, created by the extensor retinaculum. So if you're starting over here laterally, starting on thumb side, lateral side, radial side, thumb side, radial side, the first compartment here is going to have abductor pollicis longus and extensor pollicis brevis. Okay. And you'll see a deeper compartment here, that's ECRL and ECRB. This is extensor carpi radialis longus and brevis. They're kind of going under. The third compartment is another outcropper for the thumb, extensor pollicis longus. And some of this may be relevant. I mean, like if even if they're doing something like repairing a scaphoid fracture, they would need to know which parts of the extensor retinaculum they need to compromise to go deeper, so they can't just go in there just guns blazing with just cutting everything up. So they know exactly how this is lined up, so they go into the right one at the right time based on the indication. So the number 4 here, this is going to have the extensor digitorum. Now remember extensor, extensor indicis. You have one by itself for extensor digiti minimi, and then one for extensor carpi ulnaris. So it's kind of a straightforward mission here, but a bit annoying. But I would remember who is going through which. Remember who is passing through which tunnel. All right, this is a couple of cadaveric dissections here, so you can see that. So they've colored. It doesn't look like it's in real life. They've injected some sort of blue dye or something into this, but this gives you a sense of where the synovial lining would be on the inside. So all this band here would just be these individual little tunnels that allow the extensor tendons to get out to their target. See extensor longus there. There's extensor carpi radialis longus, extensor carpi radialis brevis. to the dedicated tendon there, the extensor indicis. It's a second tendon going to your index finger. Cool. Yeah.
I have a question about that.
Mhm.
So, do those two tendons like eventually like kind of go side by side, or are they overlapped?
Yeah, usually the indicis tendon is a bit medial to the digitorum tendon. And the way all of the tendons that are destined for pure 2 through 5 digital extension, they end up fanning out into that extensor expansion. So the indicis is normally a little bit medial to the communis, or the extensor digitorum tendon, and they all just sort of blend into that big extensor expansion, which has that collateral and that central band, so they all end up kind of acting together. Here it is, ganglion cyst. Has anyone ever had a ganglion cyst? They're really common, really, really common. So a ganglion cyst is it's just a benign little cyst that occurs in different places of the body. They can occur at lots of different joints, but they're usually just outpouchings of some of the synovium. So remember the little synovial sheaths that are traveling through here guiding this. You can develop a cyst like a little bleb. Using an artery term, it'd be like a little aneurysm almost that just kind of comes off the side, and it's just filled with synovial fluid. That's it. It likes to come up on the dorsum of the hand. I get one sometimes. It just kind of comes and goes. If it gets really big, it can be kind of painful if I'm in full wrist extension like this. But, typically they can go in and cut it out. I mean, they can go in and find it and cut it out like that if it really is a bother. Historically, they would hit these with very large books. Maybe if you're familiar, if you get one that comes up, they just grab a big book and like smash it so it just pops, and so you can get these kinds of cysts. Yeah.
I was just wondering, is it, because it's called the extensor retinaculum, does it cross over into a flexor retinaculum on the other side? Because I know you can get like smaller cysts in here.
Mm-hmm.
Is that the same?
The same principle, yeah. So the retinacula are just thickenings of the whole fascia. So you have a fascia that covers your hand, a fascia that covers your forearm, and it's just kind of thick around your wrist. So the extensor would end up being continuous with the flexor retinacula, and the cysts would come on the front side for the same reason they would come on the back side. So the synovial sheaths that line the extensor tendons are just like the synovial sheaths that would line the flexor tendons on the front. So anywhere you have these, you can get these cysts. They tend to be more prevalent in some places than others, the back of the hand being a big one. Yep.
So when they remove it, is that hard? Is that like, is the synovial fluid, what is that? Is it like fluidy? Like?
It's pretty, yeah, it's, I mean, I guess it'd be under a little bit of pressure in there. But, yeah, it's not like mine, when mine comes up, it's soft. Like you
No,
can
but like when they
squish
take it out like that, how is that like with the?
I'm not sure the consistency. I imagine it's pretty soft. Like if it's a fresh cyst and it's still got synovial fluid in there, then yeah, pretty soft. But I mean, it can be painful, but usually not too big of a issue. These cysts, the principle of getting these cysts from synovial linings can become problematic. So you have these synovial linings on the inside of your joints, right? So if you have a synovial joint and you have maybe a bursa or something that's coming off that joint that's allowing some sort of movement, you can get cysts that grow off those joints as well. So you can get some that grow off your shoulder and can impinge your nerves. So that's the bad. So it just should be a big bright signal TT wave on. All right, ganglion cysts. All right. The snuff box. A little bit more about the snuff box. So I would definitely put a star on this. Okay, put a star on this one. So if you were to dig a little deeper in the anatomical snuff box, literally, then you would see the extensor pollicis longus here as an important boundary. And you would see kind of together, the abductor pollicis longus and the extensor pollicis brevis tendon would be on the other side boundary. So that makes kind of almost like a little triangle shape. A couple of important contents I would be familiar with here. One is a derivative of the radial nerve. So you would see a branch of the radial nerve coming across the superficial branch of the radial nerve. We talked about radial nerve, right? So radial nerve splits into superficial and deep branches. The deep branch is going to become the interosseous, the posterior interosseous nerve. You're thinking more muscle innervation activity, but the superficial branch of the radial nerve would actually go on and help supply skin over the lateral dorsum of the hand, just like this. So this little pink area. So it's a pure cutaneous nerve, superficial radial. But you'll see some of these branches. I find them all the time in dissections. They crawl over the back of your hands. It's just doing pure cutaneous innervation. And if you look down inside of the snuff box, you would see the radial artery. Definitely the most important component, actually, of the anatomical snuff box is the radial artery. So remember, we had a radial and ulnar arteries that were on the front of the forearm like this. They both bifurcate a couple of ways to make arches in your hand. The chunkiest portion of the radial artery continues kind of posterior through your snuff box. Okay, went into your hand from a different direction. So that's where you would see it. Very reliable location, you know. And then the floor of the snuff box is the scaphoid bone, which is a bone in your wrist that we'll talk about next time. All right, radial artery, branch of the radial nerve, anatomical snuff box. Superficially, you'll see actually the cephalic vein. So mine is perfect. Mine is textbook. I can see my cephalic vein passing right over the snuff box. So you might see a little superficial vein here as well. All right, just because we can't talk about it enough, the radial nerve, So a good way to get good at anatomy is to consider the pathways of these things. So points of perilous passage is how I like to refer to them. Points of perilous passage for the radial nerve. So the first point of perilous passage for the radial nerve will be along the midshaft of the humerus. So that's an important point of perilous passage. So the humerus can fracture here and cause you radial nerve problems. Radial nerve we see come down, and we'll see it bifurcate into a superficial and deep branch. There's a good picture here so you can see the superficial branch coming off. We now know the superficial branch is just sensory, and it's providing skin sensation over the lateral dorsum of the hand, just like that. The radial nerve continues down, the deep branch of the radial nerve, right, would go through the supinator, pop out and change names to the posterior interosseous nerve. We can see all of its all these, look at all those, just little motor branches going into the extensor compartment. They don't have special names, they're just going into all those muscles, and you just have to know that this nerve is innervating these muscles, but all derived from radial. You'll also have usually a higher nerve that comes off here. Oh, they did put it in here. Here it is. So there's a nerve that will come off a little bit higher, poke through the fascia, and enter territory back here. They call this the posterior cutaneous nerve of the forearm. You might remember back from this challenging day we had together recently, the brachial plexus day. There's a medial cutaneous nerve of the forearm. It's a derivative of the medial cord. The lateral cutaneous nerve of the forearm is a derivative of a musculocutaneous nerve. This is the posterior cutaneous nerve of the forearm. So this all together will ensure that our forearm gets cutaneous innervation. So at the end, everything here in red is radial nerve sensory territory. You see all that? All right, so thinking about how this may work, we'll do it together. Think together. Lesions. So if you had a lesion to the radial nerve in the triangle interval, remember the triangle interval is bound by the inferior border of teres major, long head triceps, shaft of the humerus, makes a nice little triangle. The radial nerve and the deep artery of the arm are immediately applied directly against the humerus. Directly against the humerus. So if you fracture the humerus here in the mid-shaft, that's the term, mid-shaft humeral fracture, then the contents of the triangle interval are suspect of damage here. So thinking about that, let's work through it together. This is worth our time. Kind of modeling how to think about these. So if you see this, your next thought, if you see this deformity here, mid-shaft humeral fracture, you're like, okay, radial nerve could be an issue, deep artery of the arm could be an issue. They're right in the triangle interval there. What kind of problems would you see? So if I lesion the radial nerve up here, what would you see? What would the patient complain of? Well, they're going to lose all of this, right? Everything, all the skin sensation that's provided by the radial nerve has been cut off. So if you knew the anatomy and you're just, this person comes in, they have a deformity in their arm, you got to figure it out, right? So they're just coming in like this. Okay, so let's get an X-ray. So you get an X-ray, you see the mid-shaft of the humerus is fractured. Your next thought is let's do a neuro exam. Let's see how this nerve is playing out down here, because you know You're not worried about median, you're not worried about suprascapular, you're not worried about dorsal scapular, you know the anatomy, so you're worried about the radial nerve. So you would test the radial nerve territory, you say, all right, let's test median nerve, that's okay, ulnar nerve, that's okay, radial nerve, I can't feel that. Okay, so then you're more worried about the radial nerve. So that would cover the skin sensory problems. What kind of motor problems would you see if your radial nerve stopped working? Well, down in the forearm, the motor problems you would see, the muscles that would be affected because they receive the radial nerve would be the muscles that extend the wrist and extend the digits. Yeah? So if you can't extend the wrist and you can't extend the digits, that would be another clue that you're, maybe worried about the radial nerve a little bit. Does that make sense? So all of these signs and symptoms and clues kind of coming together, coalescing to suggest radial nerve injury in this. A concept to understand in anatomy is, and I think I may have mentioned it before, but you can't really shut your muscles off. You may feel like, okay, my muscles aren't working, I'm just laying in bed. But your muscles always have to have some amount of tone to them. You can't shut them completely off. So because of that, if you have a muscle and a group that's an antagonist group, maybe, for example, the muscles which flex your wrists, like we talked about in the last hour, and in this hour, the muscles that extend your wrists, they're both vying for the radiocarpal joint. They're both vying for flexion extension on your wrist joint. And since they're always active, a little bit of tone all the time, if you lose one group, then the other group is going to take up that space. You won't even have to try. So this is why the radial nerve lesion here shows up as a wrist drop. So they call this a wrist drop sign. And the reason is because if your extensor muscles quit working like this, and they're done, okay, they're not working at all, they're denervated, you have full lower motor neuron injury, then the flexor muscles on the flexor side are like, okay, I'll take it. So they take the slack and they pull your radiocarpal joint, your wrist joint, into flexion. All right, so we see, I think this is a gift. Find out. This is a classic netter. Like, okay, this is okay. So this is the sign. So this is a real case report. So you can just read through how they present it. So it's a wrist drop here. Another way you could get, if you didn't have a midshaft humeral fracture that was a little less ceremonious, is what they call Saturday night palsy. So Saturday night palsy is if maybe you just finished your anatomy exam and you and your friends are heading out and you have maybe a little bit too much fun and you fall asleep or pass out maybe, and your arm is draped across a chair or a park bench or something like that. That's how they always describe it. Then you're compressing the radial nerve against the humerus, which has the same kind of effect as lacerating the nerve. So if you're compressing the nerve, then you may also affect the radial nerve, which will lead to a wrist drop. I think this is okay, yeah. So we're asking, okay, so extension here, extend that one and you don't see anything. So this patient would have a right side wrist drop. Extension over here on the left side is okay though, right? All right, not too bad. All right, that's all I got. Any questions? Extensor compartment, yeah.
I was just wondering if you could explain, like, physiologically why the ganglion cysts form. Is it because of friction, or do some people just prone to them?
Yeah, that's a great question. I can't. I don't know.
Okay.
I don't know why they form. If it's just a predisposition that some people have for them. If it's like maybe just the profile of their morphology. It's hard to say. It's hard to say. Sometimes this is sex specific. Like women maybe more for one thing, or men maybe more for other things. I don't know if that's the case or not. It's a good question though. Yeah.
So, I've always heard ganglion cysts called Bible cysts.
Yeah.
So, I've always heard that you smash it with the Bible.
Yeah,
Does
like
that,
big book.
But does that cause like any, like if it keeps happening repeatedly and you keep just doing that, will that cause any like damage to the area, to the flexors, anything like that?
I don't know. So just anecdotally. So like growing up, I had known people that did that, and that's how I learned it too.
Yeah.
That's right. And they just carried on doing it.
Yeah.
they just because it would keep coming back, and they would just keep doing it. So I guess the synovial lining may just eventually heal itself enough to where it'll hold more fluid, and yeah. So I guess it just kind of stays patent and just fills up over and over again. I also know that the surgical like the definitive surgical treatment for that is actually not even that great. It can still come back, so, yeah. All right, well, that's all I've got. Thanks for your attention. Remember, hand tomorrow at 11 a.m. And that'll give you a lot of time to prep for the exam. We'll also do, so I will hold a review session so we can practice some of these things together and you feel nice and confident. Maybe, what do you guys think? Should I do, like, closer to the end of next week is probably when
Yeah.
your anatomy anxiety will be peaking? Before that, it probably wouldn't make sense, because you have an exam Tuesday, right?
Yeah.
Thursday, Friday, maybe gives you the.
Yeah.
Yeah, I think it would be good to kind of see, maybe do some of my practice questions, and that way you can see how things work and feel where you're at, and know your strengths and weaknesses, and you have some time to address that. Okay, good. Thank you all. We'll see you next time.